Hello and welcome to the second part of the lecture of diagnosis and treatment planning. In this presentation, we are going to discuss in detail various pulp vitality tests. What is pulp vitality test and why it is important? In certain situation, we need to test whether the tooth is vital or not, or whether the tooth is capable of repairing by itself, or will it maintain the vitality, state of vitality, or will it go into necrosis or destruction? So in order to determine that, we have pulp vitality tests. So it helps to determine the vitality of the tooth. It tells us the pathological status of the pulp. So, but one problem which we have is that the traditional methods used to test the pulp vitality basically depend upon the nervous innervation of the pulp. That is, they are simply test whether the nerve is working or not. But in most of the cases, this is a poor indicator of the vital status of the pulp. In many cases, the nerve fibers will only get destructed at the late stages. Maybe the vital tissue and cells might degenerate first, and only on the last stage, the nerve fibers might die. But still, if we use the traditional methods, it will show a positive response to pulp and vitality testing. So this is one of the main disadvantage of traditional pulp testing method. Let's see how it is done, and let's see what are the latest advances in pulp vitality testing. So to start with, let's discuss briefly regarding the pulpal innervation, how the pulp is innervated by different types of nerves. The main innervation of pulp is by A fibers and C fibers. Under this, A fibers is divided into A beta and delta. Majority of A fibers is A delta fibers, which are myelinated fibers which are having short diameter. They are located mainly on the periphery of the tooth. As you can see in this picture, it is located on the periphery of the tooth. And in the core of the tooth, we have C unmyelinated fibers. A delta fibers are responsible for the transmission of sharp shooting type of pain, and C fibers is responsible for mild, dull, aching pain. The traditional pulp testing methods depend on the pulpal innervation of yield false positive or negative response, as I explained earlier. The newer pulp testing devices detect the blood supply of the pulp through light absorption and reflection and are considered to be more accurate and non-invasive. Now, in newer times, we have advanced pulp testing devices which does not rely on nerves for assessing the pulpal vitality. They detect blood supply of the pulp by means of light absorption and reflection, and they are more considered to be more accurate than the traditional pulp vitality testing that mainly relies upon the nervous innervation of the pulp. So various type of traditional pulp testing is thermal test, electric pulp test, anesthesia test, and test cavity. Under thermal test, we have cold test and heat test. So basically, in traditional method, we are assessing the sensory response of the tooth. So the term pulp vitality is not accurate. The correct terminology should be pulp sensibility. So pulp sensibility is defined as the ability to respond to a stimulus, and so an appropriate term for the typical and common clinical pulp test is such as thermal and electric test, given that they do not detect the measure blood supply to the dental pulp. The pulp is deemed normal when there is a response to the stimulus provided by the sensibility test, and this response is not pronounced or exaggerated, and it does not linger. Pulpitis is present when there is exaggerated response that produces pain. Pulpitis can be considered as reversible or irreversible depending on the severity of the pain and whether the pain lingers or not. So basically, if the pulp is normal, the sensibility test will be normal. That is, when it compared to the normal tooth, the sensibility test is normal. The response is not exaggerated and the response is not lingering. Whereas in irreversible pulpitis, the response can be exaggerated and can linger. The absence of response to sensibility test is usually associated with Likelihood of pulpal necrosis. The tooth is pulpless or has previous root canal therapy. If the response is negative, it indicates that the pulp is either necrosed or the tooth might have undergone endodontic treatment in the past. In the test of cold and heat, normal findings is that patient reports sensation, but it disappears immediately. That is the normal response when the heat and cold test is considered. But abnormal findings include painful sensation even after the removal of the stimuli, which indicates that the pulpus has undergone some kind of irreversible damage. And even after the removal of the stimulus, the pain is persisting. Or in other cases, there is no response at all. In this case, the pulp is damaged. There is no vital tissue present. So there is no response, and we can conclude that the pulp is more likely to be necrosed. And the thermal test is divided into two types, that is cold test and heat test. The pulp sensitivity test, thermal test, is divided. It is divided into cold test and heat test. Under cold test and heat test, there are several categories. First one is ethyl chloride, which uses -5 degrees Celsius. Then we use ice, regular ice of 0 degrees Celsius. Then we use refrigerant sprays like carbon sprays, like ethyl chloride, etc., etc. And we have carbon dioxide snow, which are having -78 degree Celsius, and difluoromethane of -50 degree. We have heat test, which consists of gutta percha and impression compound. Coming into the cold test, when cold test is used, it is used in form of sticks. That is, apply ice on cervical third of the tooth where enamel is thin. Use ice stick, dry ice, carbon dioxide snow, or refrigerant spray. In case of normal pulp, the response lasts for 1 to 3 seconds. In case of pulpitis, the response lasts for minutes. If the tooth is necrotic, there is no response. Use of rubber dam for isolation is mandatory. Ice sticks melting ice will run into adjacent teeth and gingiva, resulting in the false positive result, especially in case of lower tooth. Alternatively, you can use ice sticks in most of the cases. The ice stick should be placed where the enamel is thin. Ice sticks can be prepared by using filling empty cartridges, LA cartridges with water and refrigerating it into ice. Usually, a rubber band isolation is mandatory for ice sticks test because the melting ice will drip into adjacent tooth and false positive result can present. Other than ice stick, we can use spray with cold water directly against isolated tooth, application of cotton pellet saturated with ethyl chloride, or frozen carbon dioxide snow. This frozen carbon dioxide snow or dry ice is a very reliable method because it can penetrate the full coverage restorations and can elicit a pulpal reaction to the cold because of its very low temperature. And studies show that even at this negative temperature, the pulp still remains white. It cannot produce any permanent damage to the pulp. So this diagram shows how the cold water is used to test the vitality of the pulp. The tooth is isolated properly by using rubber dam, and the cold water is applied directly on the tooth in order to elicit a response. Coming into the heat test. We can use use heated water with syringe, or we can use a heated gutta percha, or you can use a rotating rubber cup. Heated gutta percha and place it over cervical third of the tooth where enamel is the thinnest. Normal pulp response lasts for 1 to 3 seconds. Pulpitis response lasts for minutes, similar to that of cold test. And in case of necrotic pulp tissue, no response is produced. This diagram shows the heated gutta percha is placed over the over the tooth to elicit a response. As you can see, this is the heated gutta percha. Alternatively, as I explained earlier, the hot burnisher can be used. That is, a heated burnisher is placed on the tooth. Hot compound or any other heated instrument can be used for heat test. Use of frictional heat produced by rotating polishing rubber disc against a tooth surface can also be used. Pollution disc can be rotated without cooling on the surface of a tooth to produce heat. Deliver warm water from a syringe. This is used especially with porcelain or full coverage restoration. If the tooth is having any porcelain full coverage restoration, we can deliver warm water from syringe. Rubber dam isolation is of course mandatory while using water and syringe, as I have shown in the previous images. Now let's move on to electric pulp testing, which is other method of testing other than thermal. Here we are using electric current to elect a response in the pulp. This is done by electrical excitation of neural elements with the pulp using an electric pulp tester. They can be battery operated or have power plug source. A positive response shows pulp vitality. Negative response shows as pulp necrosis and non-vitality. So basically it is an electronic device which is powered by a battery. It is having a probe and a reading here. It is also having a connection for a metallic loop. So it is attached to the patient's oral mucosa and the tip is placed on the tooth. And once the circuit is complete, the current will pass through that. And the threshold of the current is slowly increased. Upon increasing the current, the patient will experience a response if the tooth is negative, if the tooth is white. If the tooth is having any abnormality, an early response or exaggerated response is produced. If the tooth is not responding to any amount of current, we can conclude that the tooth might be necrotic. So this is how the test is done. We place the tip of the instrument here on the incisal edge of the tooth. We will use an electrolyte in order to facilitate the pass of current. Ideally, each tooth should be separated by using mylar strips so that current won't pass through each tooth and produce false responses. And as you can see in this picture, in this video, you can see a clip which is attached to the corner of mouth, which completes the circuit in the oral cavity. So this is how electric pulp testing is done on the patient. If vitality of a tooth is in question, the adjacent tooth and the contralateral tooth can be tested upon as a control. Here, as we see, the thermal test and electric test, it's not conducted on the tooth of question. It is usually conducted on the contralateral tooth and also on the adjacent tooth in order to compare. Then only we get a comparison between different tooths. So usually the response is compared with a normal tooth. Compared to normal tooth, the tooth in question has an exaggerated response or a negative response. So we always need a control tooth for comparing the vitality. So this is very important when we test the pulp sensibility testing by using thermal or electrical methods. Another test which is used not so frequently to assess vitality is the anesthesia testing. If all other tests fail, that is, if the thermal and electrical tests fail, we'll move on to other methods in which we can differentiate the tooth, its tooth's pulpal status. So anesthesia testing is used when the patient is not able to specify the site of pain. Even after conducting cold test, heat test, and electrical test, still the patient cannot cannot identify the tooth. We'll use the anesthesia test. The main objective is to anesthetize a tooth at a time until the pain is eliminated. So we will start from the most posteriormost tooth and we'll give intra-elementary injection given to the most posterior tooth in the suspected quadrant. So if you're having a quadrant in suspicion, we'll give intra-elementary injection and we'll start from the most posterior tooth and we'll progress anteriorly. If the pain persists even after anesthesia, repeat the procedure to the next teeth mesial to it. So first we'll test on third molar, then we'll progress to second molar, first molar, and so on. So, and we'll repeat it until the pain disappears. Another test which can be used as a last resort if all other tests fail is a test cavity. Used when other methods are inconclusive. Cavity preparation will directly prepare a cavity on the tooth of question until using a high-speed instrument and adequate water coolant. Usually anesthesia is not given, and the patient is asked when the sensation or pain is felt. And if the pain is felt, we will continue the treatment. If it is not, we'll fill it with the restoration. And there are certain, as I explained earlier, all these conventional methods mainly rely upon the neural response of the tooth. There are certain newer pulp vitality testing modalities which actually measures the pulpal vitality by measuring the blood supply of the pulp. So three of the most important advances is the laser Doppler flowmetry, pulse oximetry, and dual wavelength spectrophotometry. Laser Doppler flowmetry uses the principle of Doppler effect in the moving vessels or capillaries of the dental pulp. So it compares the moving blood vessels and they assess the vitality of the tooth. Pulse oximetry measures the oxygen saturation of the blood and will determine whether the tooth is vital or not. And dual wavelength spectrophotometry is similar to that of the laser Doppler flowmetry. It uses two wavelengths and it measures the rate of oxygenation and of hemoglobin present in the pulpal blood. So these are advanced diagnostic methods which is not available commercially as frequently as other methods. It is still under research, and but most of these methods are proven to be very effective, especially in the case of trauma, where transiently the pulpal vitality test will can produce false positive or negative effects. So this kind of modern advanced diagnostic aids, they directly measure the exact vitality of the pulp. They does not rely upon neural response of the tooth. So this is considered to be more accurate than the usual pulp sensibility testing. So we completed the pulp vitality testing. We'll move on to radiographic examination. Radiographs are a very important adjunct to clinical diagnosis. But one thing which we need to note is that radiograph is only supplementary. Radiograph can be used to detect multiple canals, multiple roots, resorption, caries, defective restoration, root fractures, and state of root maturation and apical development. So we cannot reach a conclusive diagnosis by radiograph alone, but it is usually serves as an adjunct to clinical diagnosis. So this diagram compares a normal radiograph, periapical radiograph, with a radiograph with a lesion. Here we can see that the enamel dentin and pulp is normal, and the periapical tissue is also normal as well. But here in this picture, the pulp is the coronal portion is having a very heavy restoration, and the pulp canal is radiopaque, and you can see a reducing lesion with respect to the mesial root. So this is a pathological state, and this is a normal radiograph. And based upon the different diagnostic methods, diagnostics, and clinical symptoms, we have certain diseases that is which comes under the category of pulpal and periapical condition. So for the first condition or the diagnosis, is a normal pulp, wherein the pulpal tissue is of normal physiology, does not show any symptom, and the radiograph is normal. But after that comes the disease stage. The first stage is reversible pulpitis. In this stage, we have only mild symptoms, but the pulp is still capable of reversing into its normal state. From irreversible pulpitis onwards, the reversible damage starts. So it becomes irreversible pulpitis, then it will progress to necrotic pulp. Then other stages of disease like apical peritonitis, acute apical abscess, chronic apical abscess, and condensing osteitis. Now we'll discuss these things in detail. The normal pulp is symptom-free. There is no spontaneous symptoms. They respond normally to the electrical and thermal pulp test. It responds to pain with pain to test when applied. Pain disappears after removal of the stimuli. This is the characteristic feature of a normal pulp. But response to cold testing and effects last only for 1 to 2 seconds, then disappear. Radiographically, show normal periodal ligament space and intact laminar dura. But when it comes to case of pulpitis, there is some amount of inflammation to the dental pulp. So clinically, it is divided into the reversible and irreversible. But histologically, it is divided into acute, chronic, or hypoplastic. So the first category in pulpitis is that it is reversible pulpitis. So pulp is inflamed, but the condition is reversible. That is reversible pulpitis. Pulp return to normal after the removal of the cause. So here the cause will be usually dental caries, or maybe sometimes trauma or any other non-caries lesion. But the pulp is capable to return into its normal state when the causative agent is removed. It is usually presented with caries, defective restoration, exposed area, etc. There is a discomfort or pain on sweet, cold food and beverages. It lasts for a few seconds and then relieved. The pain is never spontaneous. So it happens only when the stimulus is applied, and as soon as the stimulus is removed, the pain also disappears. This is a classical symptom of reversible pulpitis. And what all tests can be done? We can do a cold test, which responds positively enough for diagnosis. Electrical pulp test also responds positively, which means that pulp is still vital. And in radiograph, there will not be any radiographic features because the pulp is in a reversible state. The laminar dura is intact. The periodal ligament is normal periapical area. The treatment offending stimuli should be removed. That is, if there is any caries, the caries should be restored. If dentin is exposed, it should be sealed. In case of deep caries, direct pulp capping technique is applied. And the proper restoration should be given so that the stimulus cannot irritate the pulp anymore. Under these circumstances, the pulp will revert to its original state. The next category under pulpitis is the irreversible pulp. Here, irreversible damage has already taken place. So the symptoms include spontaneous sharp pain, lasts for minutes or hours, poorly localized, referred pain can occur, interfere with patient's sleep, aggravated by hot, relieved by cold, analgesics is ineffective. You can use a heat test which responds positively enough for diagnosis. Radiographs, light widening of pedal space, periapical radiolucency present only if infection has passed the apical foramen. And irreversible pulpitis, the pulp is inflamed beyond repair. It can be subdivided into symptomatic and asymptomatic. The symptomatic irreversible pulpitis include pain, usually spontaneous or intermittent, respond rapidly to thermal stimuli. Pain persists even after the removal of the stimuli. Pain is sharp, dull, localized, diffuse, or referred. Radiographically, there can be widening of the pedal space. Sometimes no sign of pathology can also be seen. Next comes the asymptomatic irreversible pulpitis. Tooth with deep caries or apical lateral radiolucency. And there is deep caries, but there is no symptoms. That is a difficult situation to differentiate. The patient may present with a deep caries enough to produce a response, but there are no symptoms. Clinically and radiographically, caries extended to the pulp. Patient complains of no symptoms. If left untreated, tooth may become symptomatic, pulp become necrotic. Treatment include RCT should be done for this tooth as soon as possible. The next important diagnostics is the necrotic pulp, which means the death of the dental pulp. Symptoms can be asymptomatic, history of pulpitis or trauma will be there, but discoloration of tooth may be a clinical symptom which is easy to be noted on when the patient comes into clinic. Tests include response negatively to thermal and electrical pulpitis since the pulp tissue is completely necrosed. Response positively to percussion or palpation if only the apical infection is present. If the necrotic tissue produces an apical inflammation, then only it can respond with with percussion test or palpation test. In the radiograph, the laminar dura will be intact and a slight widening may be seen sometimes. Periapical radiolucency present only if infection has passed the apical foramen. And the treatment is nothing but root canal treatment since the pulp is dead. Coming into apical periodontitis, the pulp is necrosed, the infection has crossed apical foramen, then there are changes in the periapical periodontium. So the symptoms include pain on biting and mastication. Tests include percussion palpation, which usually responds positively. Radiographic features include slight widening of the periodontal space and may or may not be present. In acute cases, there won't be much pedial space widening, but in chronic cases, there can be a clear pedial space widening. Periapical adolescency may or may not be present. So, coming into the first category under apical periodontitis, that is symptomatic apical periodontitis, which include inflammation of periodontal area of the infected tooth. The tooth responds to biting, percussion, or palpation tests. The tooth may or may not respond to vitality testing. Radiographically, widened pedial space will be noted. Apical reducency may or may not be seen. The treatment usually include a root canal treatment. In case of asymptomatic apical periodontitis, which is contrast with symptomatic, inflammation and destruction of apical periodontium that is pulpal origin. Tooth shows no response to vitality test, no response to biting test. It feels different. However, that may be only the symptom which is reported by the patient. Tooth exhibit apical radiolucency. Patient does not complain of any symptoms. The treatment is also obviously endodontic treatment. So the main difference is that there is periapical changes, but the patient is not having pain. The only complaint patient might say is that the tooth may feel different for the patient. And then we have acute apical abscess, the inflammation reaction to pulpal infection and necrosis, rapid onset, spontaneous pain, tenderness of the teeth to pressure, pus formation, swelling of associated tissues. Tooth is tender to biting, percussion, and palpation test. Tooth will not respond to any vitality test. Radiograph, there is slight widening of pedial space, may or may not be present. Periapical reducency may or may not be present. Cervical and submandibular lymph nodes will be enlarged. And it may be tender on palpation. Treatment include drainage of the abscess if localized and followed by RCT of the offending tooth. Then we have chronic apical abscess, inflammatory reaction to pulpal infection and necrosis, which is gradually in onset, little or no discomfort. Sinus tract with pus discharge is usually a sign with little or no pain. Vitality test, there's usually no response. Tooth usually not sensitive to biting test but feels different. Radiographically, apical radiolucency will be seen as you can see in this picture. This is the periapical abscess. It's a diffuse radiolucency. Treatment is endodontic treatment for RCT. Sinus tract will resolve after a few days to months from endodontic treatment. If sinus tract is extraoral, it will leave a scar. Finally, on the diagnosis is the condensing osteitis. It is a reverse of periapical radiolucency. That is, periapical radiopacity is found. So it is just opposite of that of a chronic periapical abscess. The tooth with apical localized or diffused apical radiopacity. Tooth can be vital or non-vital. Treatment, if pulp is normal, no treatment is needed. The pulp is reversely inflamed, RCT is indicated. It should be noted that even with successful endodontic treatment, sometimes condensing osteitis is not resolved. So it is not not fully understood. It is usually seen in young patients, and it is the response is the pulpal response is usually the periapical response is usually by depositing the bone instead of radiolucency. You can see a radiopacity associated with the infected tooth. So that's all about the different diagnostic categories which can be encountered during the pulpal diagnosis. That include normal pulp, reversible pulpitis, irreversible pulpitis, necrotic pulp, apical periodontitis, acute apical abscess, chronic apical abscess, and condensing osteitis. So diagnosis, this is all about the discussion about regarding the diagnosis. So diagnosis is a important aspect in determining the course of the teeth. So the correct diagnosis is very important for proper treatment planning, and it also dictates the future of the teeth, whether the teeth should go for a restorative treatment or should go for a endodontic treatment. Thank you.